Thank you so much for meeting with us today, Melinda Durr. Do you think you could introduce yourself a bit for our audience?
Sure, no problem. Melinda Durr. I'm a partner based out of a Chicago office with EY-Parthenon. I lead our payer strategy practice, and as I say, it involves a whole host of things. One of the main areas that we focus on is value-based care. Through the context of both payers and providers, really looking at how do we move the market towards outcomes. And so that can be a whole host of things, from designing payment models, understanding data, both on the provider, the consumer, and the payer lens, redesigning clinical workflows, and actually tracking and ensuring that the metrics we want to achieve are achieved through the program. So a lot of experience here and a lot of innovation occurring in the market.
And I know an important subcomponent of many of the value-based care models has to do with how you drive that behavioral change we need from everybody, especially providers, with some kind of incentives, disincentives, the monetary part. Is that an area that you can elaborate a little bit more about?
Yeah, I think your statement is completely correct, right? Having the most aligned incentives is really critical. I think one of the things that, as we continue on this maturity model, and I emphasize maturity model because we're probably in value-based care version 10, 20, take your pick. I think there's an appreciation around understanding not only what are the incentives needed to drive behavior change, but an appreciation that we need to realize where the providers are and where the payers are. When I started working in this space a decade plus ago, everyone kind of came to the table and said, if we put the right incentives in place, whatever those incentives are, it's a little field of dreams. Build it and they will come. I think we're realizing more and more that that's just not true, and creating incentives and passive incentives that scale and change as the maturity of both sides of the relationship mature is really critical to achieving long-term sustainability and success. And, it's one part of it, but a really important part of it, and one that if you don't get it right from the beginning, I think limits your effectiveness.
I'd like to kind of focus on one or two key instances, alternative payment arrangements that you were instrumental in designing, implementing, maybe both. And drill in a little bit more, especially what were the problems that they were trying to solve or the opportunities they were trying to capitalize on?
Yeah, so I've done a number of these arrangements, and again, both on the provider and the payer side. From the payer perspective, as you design a reimbursement structure, and look, the payer, despite the fact that, I think they would say we have a role in enabling workflows and a whole host of other things around clinical delivery, the most important piece in my mind is getting the payment structure correct. Making sure that they understand the incentives that motivate the provider, that they're appropriately incenting and rewarding the provider for outcomes. So I've worked with a local Blues plan. They're in multi-states, but they are not a national plan, and thinking about their value-based care strategy. And, the first thing that we did as we thought about the program was, what were the aims and objectives? What were they trying to accomplish? And then really thinking critically about how many of their providers are ready, right? So I call this a path to risk strategy, where you're thinking through and you're actually, I'll just say, stage gating the providers based on maturity. And the incentive model, the reimbursement model needs to change as they mature and as they grow through and achieve outcomes, in all honesty. The first piece is just, what are those components, right? So you can start from a minimum of, we pay for performance, or some upside incentives. Could be for data. That's an easy way to start data flows and understanding of parties. Could be on certain metrics, whether they're clinical admin metrics or some outcome metrics related to a population. And moving forth into greater incentives, we typically call that upside only, right? You achieve certain outcome metrics and therefore you get a greater share of either the savings or the reimbursement. I don't think there's one that's better or worse. We see kind of both of those models. And then moving into upside downside. So the difference between what I call kind of a true capitation model versus upside downside is the risk is capped. So it's within a form of guardrail that is defined and agreed to. And so each of those are really critical. The other piece that I would say is, it's not just the monetary components of it, it's what are the metrics and outcomes that determine when you're ready to go to the next stage. So that's really on the payer side. A lot of the work and the focus happens there to define that. And then what I would say back to the slotting is, how do you think through your provider network and who's really ready to come to the table, not just from a readiness perspective, but from an importance perspective for your members and your network, right? So that's how we think about that on the payer side at the highest level, and happy to go into more detail.
Well, I wanted to ask, I think, a couple of sub-questions there. One, you talk about readiness, and there's a lot of it in the literature. What does that really look like? I'm imagining you're at a table with your payer or with their key providers in the network. How do you gauge where they are on that continuum of readiness for risk?
So it's different for a provider than for a payer. I do think for a payer, they have to realize that going on this journey actually means some critical decisions about their provider network and their enablement capabilities, and honestly, how they're investing in their network. So I'll just contrast again, when I started, really what you thought about your network was broad and deep discount, right? You wanted a cost advantage. We are not into full maturity of a value-based network or a high-performing network, but when we get there, broad and low cost isn't going to be the name of the game. It's going to be high quality, targeted outcomes, and cost, right? So cost isn't going away, it's just going to be characterized differently. So when I come to the table with payers in particular, I want them to kind of be starting to talk about their network in a way that's different than just everyone's in, and really talking about the value creation that they anticipate and communicating that with their providers as well. Depending on the market, the payer is sometimes in a position to lead and should. Sometimes that's not the case, right? And so you also have to have some sensitivity towards that. And I encourage my clients to really think about their negotiation position as they go into these conversations. Just because you are not in a position to really drive the end-to-end doesn't mean you can't create value and you can't be leading. So for the payer, that is how I think about it. On the provider side, readiness is, I think, a much more complicated question. Because for the provider, truly to enable value-based care, you have to clinically transform. You have to transform the way in which you deliver care. You have to transform the way in which you're incenting your workforce. You probably have to change your clinical teams. You have to change your engagement with your members or your patients. And so that is a much harder question to say what is readiness. I think having the provider come to the table is the first step always. I've seen, and this will change, but historically, primary care physicians much more able, capable, and interested in coming to the table around these arrangements. We're starting to see some specialty groups also do that. Hospitals have been a little more difficult. The economic model is fundamentally, I don't want to say at odds, but at odds, right? Yes. That requires a whole host of change from the leadership all the way down. And so if I think about that just from the, who's ready, when I see a primary care physician come to the table and actually be able to articulate how they think about care, how they think about tracking outcomes, how they think about care teams, that's a really good indicator that they are ready. They're probably not done, but they are at least ready to engage the conversation. And then just the last piece is, as I think about these dialogues, it's a recognition of gaps and weaknesses. If two sides of the table are saying, we've got this completely figured out, don't worry, maybe except with the exception of South Florida and certain markets, but I like to hear people say, we don't understand this and we know it's important, and so we want to work on it together. Or can you help me do this, right? On either side. That to me is really important to creating a true partnership and enabling a journey versus a transactional, encounter or relationship.
Sounds like a couple of the subcomponents. One is the technical readiness. So do they need a certain EMR, or what is needed to be able to get the data with which to manage?
This is my own, I think, bias. I'm not a proponent that technology is the panacea. I think we in healthcare get really distracted on shiny new toys, and we believe that it solves all of our problems. To me, yes, there is, an EMR component, there's a workflow component. The reality is when you are delivering care, you're not going to be logging into 5 different systems in order to complete whatever you're doing. So making sure that the interactions, the prompts, and the pieces of data that need to be collected are done within a single system as seamlessly as possible, it is always the answer. But I've seen practices, and again, this is not recent, but practices that don't have heavy technology. They are using huddling strategies. They're using kind of who's on first, a very clear handoffs and workflows, and who's the care team lead versus when does the handoff occur? How do we think about the patient? Are we following up with the patient after a certain amount of time, right? Some of these things are just process and care delivery oriented. And so I think it's a mix, right? But to your question, I think it ultimately comes down to the commitment to change how you deliver care, right? And technology is part of that for sure. But I think the bigger part is the people in the process and aligning that first, and then saying what are the technology components that are needed. So EMR for sure, scheduling for sure, data, things within Medicare like risk adjustment and STARS performance are going to be really important, but also connectivity into the community too, right? So that's kind of an area where I also think there's more opportunity for us to really think through how do we kind of manage a member in all sites of care, clinic, community, and home.
Let's make sure we circle back to that in a little bit. But I'm glad to hear you say that it doesn't have to be a fancy EMR, because this research and this film series, we're spanning multiple countries. Yep. And the dynamic of EMR adoption, especially among different subsectors of healthcare, it varies radically.
Yeah.
And so it's good to hear this is not insurmountable if you don't have the latest instance of the most expensive EMR.
And I think, look, the EMR question is, I think some of the younger physicians that are coming up it's not even that they're more tech savvy. I think they're just more comfortable with technology, right? That's been part of their lives. But that doesn't mean that an older provider, a decade away from retirement, can't manage care. It's down to the clinician and the clinical asset and the admin asset within the provider practice, that all of them have to understand what the objectives are. Then they can work to achieve it, even without the latest instance of the new fancy EMR.
Well, that leads again to another nice sub-question, which you talked about workflows.
Yeah.
And now you're talking about all the different individual things that physicians do. Unpack that idea about workflows and what needs to really shift, whether it's a primary care office or some specialty involved with chronic disease or something.
Yeah, so I think back to your first question about reimbursement, right? If you go in, I'm sure you've appreciated this, go into any physician office and you sit for hopefully less than 20 minutes before you see your doctor. The nurse comes in, takes a certain amount of vitals, puts it into the system. Your doctor comes in, she talks to you for 5 minutes, 10 minutes, answers your question and leaves, right? So the first thing is we need to break that transactional cycle of how you visit patients. There's a whole host of things, and so keep me honest about this, but I even think thinking through the stratification of your patient population. So I joke, you shouldn't ever see me unless I have an acute need. I'm young, I'm healthy, I have a number of specialists that I go to for, different things that I'm managing, but on a day-to-day basis, I'm not in need of primary care. I'll contrast that with my godfather, who is a diabetic, he is an amputee, he has had cancer in his past, overweight. So he starts to become a very different type of risk profile and honestly needs far more intensive clinical intervention on a more regular basis in contrast to me. So I think first of all is understanding that population and understanding what the needs really are, and then aligning your resourcing to that. So if you are in, let's just say, a high intensity frail elder care model, right, maybe within a DSNP, dual special needs program population, you are going to be seeing far fewer people with far greater frequency versus a young and healthy population, one like a concierge primary care, One Medical, for example, that you pay and they're targeting individuals like me to say, let's keep you in wellness and health, right? So it's a different philosophy on how that happens. And then from a workflow perspective, I think you need to then align that workflow to those populations. So you have to maintain, an understanding of the clinical disease states. One of the things that as a payer person, or thinking through the payer lens, is we think about a member within a context of you're a diabetic, you have COPD, you are overweight, you have had this, and I say it's vertical, right? It's along a clinical disease state versus the whole person. And so I think one of the things is that from the workflow perspective is the whole person then redefines what that workflow is. And it's having those conversations, it's having those opportunities, it's saying, are you managing these conditions in a way that holistically leads you to health versus are you taking your insulin? Have you checked your rates of this? How much have you exercised in the past week, right? It's actually thinking about them in a different way than categories that are kind of siloed and one-off. And the last piece, and I promise I'll let you ask your next question, is I think we need to figure out a way to engage the patient or the member. I joke we don't have healthcare in the United States, we really have sick care. And part of that is because consumers are really uncomfortable talking about their health. They're really uncomfortable engaging with the fact that their behaviors have consequences. It's not easy to be healthy, right? We have around us all the time reasons why we can be less healthy. But I think that that's the last part of this around value-based care. It's one that I don't have an answer for you. I wish I did. But it's the last piece where I say when we can kind of put the payer and the provider in incentives and outcomes together, and I think we're getting ever closer. That is good. It's going to go a long way. The patient and the member is the last piece, and it's one that I don't feel we have even started to kind of crack in any material way.
That expanded nicely on the workflow question, but I wanted to follow up on that because I'm just envisioning, let's say you walk into the office and I'm a physician in a big clinic, and maybe contrast prevalent work behaviors now or practice behaviors now with what you explained. What you explained sounded great, but I thought that's what everybody's doing. Don't they all look for their diabetics? You know, admin, pull me a report of all of our diabetics and then let's see if they've had all of their screenings. Is that not happening and you come in and help them understand how they just need to do different analysis or be help me understand?
Yeah, it could be. I in no way, shape, or form want to imply that physicians aren't looking after their patients in the best way that they think they can, right? Having said that, let's just say I am a diabetic. If I'm not going to the doctor on a regular basis, or I'm not on insulin, maybe I'm pre-diabetic, right? But I'm not managing that condition, the doctor, in all fairness to her, has no way of engaging with me and helping me and preventing disease. This is why I say the consumer, the member, the patient, the consumer is such a key part of this, right? So within the walls of the clinic, when I'm there, I am getting the care that I need within the scope of what I'm telling the doctor. But if I'm not there, how do I access that, right? Again, and how do I proactively understand what could be happening, right? But I'm not having the conversation with my physician on a regular basis to say, let's go get my cholesterol screened. Let's go do this. I have a history of these things in my family. Should I be thinking about them? And that's on me. I don't think that my clinician should be, expected to do that in every instance, but that's the type of dialogue that we need to have. And again, as I think about the promise of a different type of care intervention and reimbursement, that ultimately is where I think we want to go, right? It would be on managing diseases existing today in a better, more holistic and compassionate way, and allowing clinicians to practice medicine, in all honesty, and allowing the payers to really incent for outcomes and drive better quality and lower cost. But ultimately, you do want to then have a dialogue and be thinking about not only today, but tomorrow.
Part of what I think I might have heard was a passive connectivity to the patient, where are most physicians waiting to hear from a patient who needs to be seen. Needs as defined by that patient, his or her family, whereas the model you're describing sounds more proactive. We identify somebody who likely needs consultation, guidance, proactive help, reach out to them and get them in. And the Melinda Durrs of the world, who are fit and fancy and great, maybe we send you the annual reminder. You need to come in for that annual check, and that's it.
Or I see a nurse practitioner, or I go to a minute clinic, or a specialist is, kind of the focus of what I'm doing. I mean, I'll say novel. It's not novel in the sense that but when I heard it, I went, oh, wow. Like the commitment on the physician side, this is a physician intervention, was actually, it showed me that they were pretty serious about what they were doing. So it's a clinic in South Florida. They do Medicare and Medicaid patients. They see that population with a little bit of commercial, but they require every one of their attributed patients on their panel to be seen once a quarter at minimum. So if you don't schedule, you get a call. You need to come in, the doctor would like to see you, or the nurse practitioner. If you miss, you get a warning. If you miss 2, they basically take you off the panel. And the reason why they say that is our commitment is to health. So your commitment has to be to health as well. And so they have an implicit agreement that the doctor is going to see them at some regular interval. And again, these are members with health needs, right? So they are a higher acuity population to begin with. But their philosophy is, I can't help when I don't see you. Again, you would go, wow, they've asked patients to leave their practice. But it's because of a misalignment between their philosophical approach to care and what the member needs, right? So in that, when you flip it around, I think that's actually incredibly impactful, both for the physicians, and for the member to say, this isn't what you want, and that's okay, but no, this is what we give, and you're not willing to kind of meet us where we need you to be, and therefore it's not the right match for us. So I've always kind of looked at that as, when I first heard it, I kind of had a very strong, why would you do that? And then thinking about it more, I actually go, no, that completely makes sense, because they're asking of their patients to come and participate, and that's a requirement that they need and ultimately to be successful.
And I can imagine, in addition, that would be very motivating for patients, particularly in a market has a physician shortage.
Yeah.
Where I need a doctor, and if my doctor, quote unquote, fires me, then I'll be in the lurch, and I occasionally need a doctor, so I better do what I'm told, or better cooperate.
And you can see now,
collaborate.
Even things like digital telehealth and digital engagement, right? So you could actually do this in a very seamless and non-invasive way, right? So if I don't need to see the doctor, hey, it's just my quarterly checkup, how's things going, what are you doing, blah, blah, blah. You need to prepare for this test, or let me schedule this test for you. I think some interesting things around telehealth are actually really interesting in how you can maintain connectivity while not being within the four walls of the office.
Well, and that has been a good learning or capacity building from the pandemic. Kind of forced us. We already had the technology, but it forced behavior change.
I hope so. One of the things, I was just looking at the utilization, I think it's come back down to like 4 or 5%, where it was like 15 in the pandemic, which I also was a little bit surprised. I was like, wow, 15%, I would have thought it was higher. But again, it's a little bit back to we were all in our houses, probably not thinking about, do we need to go to a physician, worried about a whole host of other things for obvious reasons, and fighting over toilet paper. So, but I think that's one where I would like to kind of see that tick up. Because for me, again, personally, and I'll contrast this with my parents, we both use telehealth. So I use telehealth as in, I have chronic migraines, I consult with my neurologist. I'm on a medication regime that's worked for me for years. I don't need to go into the office until I need something, that actually requires a change and requires an in-person visit. My father uses it in a very different way, but again, to keep tabs. Hey, I feel this. Is something wrong? Should I come into the office, right? So instead of kind of prompting that in person, he's actually, I say instead of Googling or WebMDing, he's calling the nurse practitioner to say, do I need to come in? It's 100% triage, right? And so both of those feel very valid to me. And again, to your point about limited capacity, and look, it's always limited capacity, right? There is not infinite capacity in the healthcare system. It allows the physician to be smart and thoughtful while also delivering a care experience and an outcome that's right for the patient.
I think that dovetails nicely with your comments about stratifying your patients or risk stratifying, because we can use that technology to reach out to people proactively, especially when you have a pandemic, they can't get out, or maybe they're rural or homebound. That's better than before when we had nothing until the ambulance showed up.
Exactly.
Metrics. You alluded to metrics. I definitely want to talk about metrics. I heard you say workflow and I heard you say outcomes, but for a long time we focused more, in the U.S. at least, more in terms of processes, HEDIS type measures, for example. So can you talk a little about metrics, particularly process versus outcomes, the patient reported like PROMs or experience measures, PREMs. Are these things that you and your clients are looking at today?
So yes, and I'll say but. So I think the challenge that I still see is the debate around data. And when money is tied to data, that becomes infinitely more complicated. And I have sat on both sides of the table where there have been long debates on, where'd you get those numbers? Why are those numbers included? How do you calculate this measure? This is how I calculate this measure. Why is it different? And so I do think back to a little bit of in the spirit of partnership, coming together, that is always going to be there. But I think that part of why I say coming together and admitting and understanding the gaps, strengths and weaknesses and gaps that you want to work on is so critical. So I agree. Look, admin measures, HEDIS measures aren't sufficient, but they are typically the easiest to measure, for better or for worse. So when I kind of come in and say, how are you performing? So first is just the stratification of the population, right? Do you understand the risk profile of your population? Do you then have care models or care teams that are aligned to that risk stratification profile? And I'm agnostic about how you think about that risk profile and the alignment of that, but I think that that's just a key part. I've seen physicians who truly do it on a whole population basis, which, hey, you're a risk score akin to MA risk scoring, which we can debate, but you have X number of clinical diseases, therefore you are a higher acuity, you are more likely to go to the hospital. So we have a different type of engagement model than my mother and father, who are probably a 1.0 senior and lower risk. I've seen it done on disease states too, right? We have high diabetic populations. We know that, and the other one is, depression, loneliness, kind of those things. And I've seen clinics actually kind of rotate around that to say, we're going to intervene on that, and we're going to have specific types of programs and interventions associated with that. So that's one. The other thing is a utilization, which is a little bit back to HEDIS, but in a different way. We like to see, if we're looking at kind of populations, PCP visits come up. We like to see specialty visits come down or more aligned with the underlying clinical disease states. We like to see hospitalizations go down. We like to see SNF utilization, hospice utilization for certain populations go up. So there is a site of care piece here that, as a payer, I'm looking at. More sophisticated providers also think about that, because for them, the referral patterns out are really important. Does the patient go out and come back? Or can I get to them if I send them to the hospital, right? If I determine that's the right thing, can I go and round there? Can I do the discharge planning with the hospital? Can I make sure that they get home? So that piece is important. And then from a quality perspective, yes, I think things like medication adherence for some of the HEDIS measures, to be perfectly fair, I think are an indication of outcomes, right? That you're managing to a set of outcomes through compliance or through some what we'd call process measures. And then on the consumer satisfaction piece, that's again one that I think is really important, but I don't think we have a great measure. NPS isn't a great measure, right? A Google review isn't a good measure. And, depending on the line of business, and I always say Medicare is the one that pops, but I think we all do it. Who's your physician? Do you like them, right? So that word of mouth piece is another way in which we think about it. So I think, for better or for worse, honestly, managing the MLR in aggregate and by risk cohort is probably the way in which I think we kind of think through this. So, and the reason why I say at the overall level and at the cohort level is you can have variation, right? Your MLR might not move for a certain population for a whole host of reasons, but you may be intervening in a way that's leading to better, clinical outcomes, higher patient satisfaction, and they are just higher costs for the reimbursement that you're given. That's just the reality.
The discussion on outcomes versus process measures, it made me reflect on a conversation, one of these interviews with a colleague in the Netherlands, who said, well, why would we do processes? That's like, my words, micromanaging. That's dictating to the clinician how he or she should provide care. All we really care about is the outcome. And I thought, that's all we really care about too in the US. We just think there should be standardized best practices. So thoughts on why we don't let's just do outcomes. Forget processes, utilization, all that. They'll find their own way there. We'll just measure outcomes. Why not?
So I totally agree with your colleague or the conversation. I think one is just the maturity of our clinical delivery in whole. And I think, look, the reality is even if you are a mature primary care physician practice under risk, you still are going to be doing some things under fee-for-service, right? It's not perfect. We are not in a fully value-based system. So part of the processes, I think, is to almost jumpstart how care is delivered and how care is coordinated. But you do see that these care teams are, sure, there is a daily huddle. So that is a process measure. We are daily huddling, and we have a standard way of thinking about which patients are huddled on versus which patients aren't. So that's a process measure, or that's a standard approach. What then happens in the huddle might be defined at the beginning as people get comfortable, but then I think, to your point, we trust that the care team can make the right decisions around the needed care, the needed intervention. So I think it's, again, a spectrum around how do you think about different things, and a maturity. Again, I think because process is so not easy to measure, but easier to measure, I think we are going to kind of default to that more until we feel like there is some maturity and a step change in how we all think about delivery of care under a value-based arrangement before we kind of start to think through, now we don't need to have such rigid definitions around kind of how we do things.
And in America, we've been measuring processes forever with the Medicare Plus Choice, right? And then Medicare Advantage.
Yeah.
And the pushback, as I heard it, was, well, physicians don't want to be accountable for outcomes because they only have so much impact. Thinking social determinants, genetics.
100%.
But that's true. But it's less true today than it was 20 years ago because we have data and we have processes. Yeah. And I think it's changing demographics and attitudes.
I think it's interesting if you look at South Florida in particular, which is a place where primary care-led value-based care is the model for Medicare and for Medicare Advantage in particular.
And commercial?
Not as much. And again, I think just from an adoption perspective, I've personally seen Medicare Advantage in particular, managed Medicaid, and then commercial. The heterogeneity of commercial members in terms of clinical needs and the variation, right? You could have a woman who's pregnant to a very healthy individual at any age to someone who actually has a chronic disease, by birth or at some point in their life. So I think it's more difficult, in all honesty, to deploy those members or those models against commercial. Doesn't mean that it isn't happening, right? But that's kind of the progression that we've seen. But within Medicare Advantage in Southern Florida, Miami-Dade and Broward County in particular, we have incredibly high Medicare Advantage adoption, 70%, which is highest, I think, with the exception of some parts of California. Culturally, you actually see an important component of those populations, right? They're more Hispanic in the populations within Medicare. Diversity or that cultural importance kind of infuses how the value-based care programs are deployed, which I think is really interesting. So to your point about what the doctor can and cannot do, I think there's a recognition of that, and also a recognition that if you don't understand kind of the cultural norms, the cultural flows, the expectations, and tap into that, you're going to be limiting yourself, right? And so that's another interesting part. Within that region in particular, you see much more community focus, which I think is just one of the unstated components of their long-term success.
That leads in very nicely to the next question, which was to be a different topic, but you segued beautifully.
Unintentional.
The who needs to be consulted or involved in these decisions. You sit around a table, you come up with a new model. Yeah. And initially I was thinking, physicians, hospitals, insurers, but you looped in the community and a cultural sensitivity component. So can you talk through who came together, what were the conversations like to make sure you had the right voices there to be effective?
So I think about this in two pieces. So the first is around kind of the programmatic structure, and that's the relation between the physician and the payer. So on the payer side, it would be a network team. It might be the chief medical officer. It could be members of the line of business. So again, if you're doing it for Medicare Advantage, and typically the payer will think about these as starting with a line of business and starting with a portion of the population and kind of expanding out there. So on that, it's, I don't want to say easier, but typically that's who you would see sitting at the table. Maybe an actuary too, to be fair. On the provider side, let's just say it's a primary care physician group. You're going to see typically some form of the leadership of the group. I actually think that that's incredibly important. The ability to do this actually requires a physician champion, and it has to be in a leadership role to drive the change that's needed. You could see members of the clinical staff that includes nurses and step-down clinicians. You typically will see, as the discussions progress from the office staff, right, what are some of the reporting requirements? Can we do this? How do we think about that? That part I wouldn't even say is contentious. Like, it's contentious because of the dialogue, but typically people around the table don't change. Then I think you actually transition into a lot more physician-driven deployment. So as the physician group transforms internally, you're right. Do you have physician panels that are reviewing process and outcomes? Independent. You want to kind of say, how do we come together? Compensation boards. So, and I've seen this, are we naming and shaming? So do we tote all of our physicians in terms of outcomes and metrics and performance? Do we publish that? Do we not publish that? How transparent do we want to be, right? You even see things like, are we going to let physicians go because they're not performing? So there's a whole host of things that happen, I would say, within the office. And a lot of times depending, look, if you're a 1,000 workforce physician group across multiple states, it's a lot more complicated than if you're a 100 resource group. But that kind of structure and making sure that you understand that and that you have the right reporting relationships is really important. And then to your point, what are the community members that you need to have in the flow? So is it actual community-based organizations, right? Could it be a church? Could it be another group? Are you going to have a patient panel that provides feedback to you? So I think that's, again, back a little bit to the maturity of the model. I would say that last piece is something that we're starting to see happen more and more, but wouldn't be like, again, a decade ago, that probably wouldn't be talked about consistently as a need. It would be much more around the clinical side and the decisions around how do we hold each other accountable in a way that allows us to actually achieve the outcomes we want.
And I imagine at least your payer clients, I don't know, maybe the providers, probably are doing market research to think, well, how do we best market our product to this particular demographic group? How hard would it be? Maybe not hard at all to transition that work or those connections to having those people's consultation with the delivery component, not just the marketing and messaging component.
I don't think it's hard. My pushback is, how actionable are those insights? So you can do the research. That's typically not the challenge. I think the challenge is then, how does that feedback loop actually get worked? And are you ready to work it, in all honesty? And again, I think we just have to recognize that as much as we'd love for it to be a snap, transformation is really hard at all levels, right? And so I do think, I hope, through a lot of failures, we now realize that while that's important, while having a patient or a member perspective in the center and putting the patient in the center of the clinical transformation is our objective, that isn't reasonable on day one, right? That we have to work in a deliberate way to get to that. And so it's on that path. And I think most providers, even if they are starting to move towards more holistic thinking around care delivery, different types of models, different types of care teams, they haven't gotten the third leg of the stool in scope in a way that I feel like now we're ready to tackle that consumer and member part.
I was just thinking about, like, in some Latin populations, the promotora idea. So is there somebody from the community, especially under a different payment model, where they don't have to be a billable professional? We've already been paid capitation or case rate or whatever. Let's get somebody who lives in the community, a little basic training, and they're reaching out to all of these abuelos y abuelas with chronic conditions who are a little more homebound, and we're worried about them. Yeah. And they need better attention 100%. Than historically we've done.
100%. And I think that's where you're starting to see, I'll say, pockets of innovation, for lack of a better term, in which we're saying it doesn't always have to be a clinician who's intervening. And that's...
It does if you have to bill in a traditional fee-for-service environment.
Exactly. And that's I'll just say a mental break, right? In the historical fee-for-service model into something different. And I'm an economist by training, and so my mind goes, well, if the resource costs less and you can deliver the same value, you should be thinking through that, right? You should align resource intensity with whatever intervention intensity. And you're right, the payment model 100% has to be aligned to that.
So let's transition to evaluation. And I think maybe we've segued well there. How do you know you've got these models out there in the world with your clients, payer, provider, from whichever perspective, payer, provider, or your perspective? Yeah. How do we know if this thing is working or needs to be improved?
I think from the payer perspective, it's easier in the sense that if I have, let's just say in this example, 100% of my payers under a capitated rate, 87%, whatever it is, I then know it's successful because I've de-risked my exposure, for lack of a better term. Now, obviously, I'm concerned about the outcomes of my patients. I'm concerned about satisfaction of my members. I'm also concerned that the providers aren't preventing care, or financially unstable. So I say that a little bit like, yeah, that's their intent. There's a lot of other things to go underneath that. But ultimately, I've basically set my risk exposure on different populations as a payer, right? And I have to manage that to make sure that the things I want to happen are happening. But for the payer, it's a little bit more straightforward.
What total cost of care, and are the basic metrics being covered?
The challenge is, do I have enough providers under that arrangement, right? So that for the payer is the challenge. For the provider, I think it's, again, they're going to manage it on profitability or medical loss ratios and revenue and profitability. And part of that is because, it's a business, but I think also part of it is this requires investment to sustain, right? It's not a set it and forget it. That's one of the hardest lessons that I think, looking back, I don't think it's surprising, but I think a lot of people thought, we'll set the reimbursement model, the providers will change how they practice, the patients will come and we'll be done. And that's couldn't be further from the truth. And so I think that's one where, again, the maturity, we're nowhere close to being able to do that in a consistent way. And again, as I have a lot of empathy for the providers, because let's just say, I'm a provider practice and 30% of my panel is with United and 30% of my panel is with Blue Cross Blue Shield, and the remaining 40% are with 12 other insurers. Well, if I have a value-based contract, let's just say capitation with United, that's wonderful and great, and I'm going to transform and do the things that I need to do to be successful there. How do I deal with the other 70%? Do I have two different models? That feels incredibly difficult. Do I deliver the same intensity and level of care to the 70% under fee for service when I know that I won't be reimbursed at the same level? Just that's factual, right? Or I might be close, but I have to really work to code and the admin load and everything becomes untenable. Do I go back to those payers and say, I want to go to risk and here's why, and are they willing to come to the table? And that's really the environment in which we're working. And so even things like the direct contracting or the ACO REACH model, as it's being renamed, that is great because I think it's aligning more payments towards something that isn't fee for service. But there's challenges to that too, right? As providers think about under Medicare, there is no network. Members are allowed to go anywhere. You have to create an experience which they want to come to. You have to manage referrals again, and you have one arm tied behind your back because there is no network, right? So I think all of these things are good solutions that are moving us towards greater maturity. The problem, though, that I see is they're kind of incremental in nature. But look, that's the U.S. healthcare model, right? Contrast that with single payer or other models where there is a heavier centralized role. And those problems are a little less of an issue, but in the U.S., we're uniquely challenged given how we pay for healthcare.
Various similarities to some countries, but you're right, we are a different creature. So,
for better or for worse.
Right. Both. You talked about the MLR, so the medical loss ratio, yes. The total cost of care. So everybody's looking at that. The insurer's looking at that. The providers are looking at that. You alluded to some of the basic care metrics so that payers are comforted that their patients, their enrollees are not simply being denied care.
Yeah.
What are some of the main things that are measured to ensure that care is good? We talk cost, but
it's going to be limited in all honesty. So I think some of that is going to be around agreed to measures on number of visits, how much, things like how much hospital utilization, number of scripts, those kind of things, which again, I think are processy, and HEDIS measures. Payers are also going to be looking at, I'll just say risk scores, but also are they seeing things in the claim pattern or in, if they're, I hope they aren't, but a lot of times they're also doing their own outreach, right? So they'll have a diabetic management program that's trying to engage the member who should be engaged by their physician. But again, we'll leave that for another day. So are they getting other data sources that they're bumping up against performance as well? But typically it's going to be on the agreed upon data. Some of that is going to be clinical. So it could be encounter data, right, that they're sharing back and forth. Could be claims data, because to be fair, sometimes the providers, patient goes somewhere and the provider doesn't know and the patient doesn't say that. And so the payer, even though it's delayed, can actually say, wait a minute, Melinda went here, did you send them? That's contrary to what we would have expected from you or your typical pattern. And so that's, again, back to the data sharing and the timeliness of data and the partnership, right? Can you start to be transparent and can you trust on both sides of the fence, that the data that you're looking at on either side is true, and that it can be that you're willing and able to action against it, I guess is the other way that I would frame it. And again, both sides are at fault on this. There's not one that I would say is worse or better. They all have their own silliness around this.
The utilization measures, like how are we doing on drug utilization? What categories of drugs?
Yep.
Inpatient, emergency room,
all of those things.
Probably specialty versus GP, et cetera.
Yeah. I mean, even things like how many, depending on the risk score, are we seeing patients in their home? Are we, what percentage are we seeing in their home? Is that appropriate? Are we seeing, what's even, again, interesting things I've seen, connectivity to different kind of community-based services, right? So I think that those but those are not standard. So again, we're starting to talk about what's the standard set of metrics that I think are being used better or for worse. And then how are we starting to think about what really drives care? And then back to your question around the consumer, patient, member, however you want to talk about it, how do we start to really think about their satisfaction, right? To be perfectly fair, practices they care about that. They're asking about that. I just don't think that we're at a place where I say there's one measure or one standard way to think about it.
What is it looking like the standardized measures will be?
Oh, I don't have a good answer for you.
Oh, we're not there yet?
I haven't seen one that you can do longitudinal surveys, and it doesn't have to be an 80-question survey, but getting around, do you feel like your doctor listened? Do you feel like you were given adequate information? Do you feel like your doctor is there when you need them? Things like that, I think are...
Like Medicare-driven HEDIS, HCAHPS kinds of thing?
I would say so. I think that's where we're going to start and look. HCAHP and CAHPS and HOS survey questions are challenging because of how the program is set up and the sample size. But those kind of things I think are going to start to be more and more important, not only from a programmatic perspective with CMS putting the weighting on those measures in particular, but also just, again, to start to get our arms around patient satisfaction.
We've covered a lot of bases today. I really appreciate it. In closing, one of our viewers is thinking, we really need to get on this path. What is your closing advice for how to be best poised for success?
One is really understanding where you are and what you want to achieve. I think going in and saying we want to be under a value-based reimbursement structure is naive. So that's kind of the first order, right? Where do you think you are? Where do you think you can get to? And over what time horizon? You might be totally wrong, but having that internal look and honestly, commitment from the rest of the practice or the rest of your organization is important. And then I would say, being willing to, I call it test and learn, but being willing to fail. This is not easy, right? Fail fast, learn and change. And so you need to kind of go in and know that not everything you're going to do is going to work out, and that's okay. But that being willing and that spirit of evolution and maturity on both sides, right? We thought it would work, it's not, why isn't it? How do we fix it, right? And I think we turtle a lot more than we want to, right? It didn't work, oh my God, that's a problem. So that's kind of my advice. And then obviously, and I'm sure some of your other interviewees probably had more eloquent thoughts, but I think then all of the other specifics should kind of align to that. I think the philosophy going in and the willingness to learn, grow, and change is just an initial condition that I see a lot of my clients and a lot of people trying to do this struggle with. Right? And again, it can be life and death. So I'm not saying that in a flippant manner, but I think, look, this is something new and not defined. And in the spirit of it's ambiguous, you then have to be willing to kind of run the path.
I'm glad you talked about the value of learning. I know in the Netherlands, that was a prevalent thought I heard was, well, we might save money, we might not, but we want to learn about this. Yeah. And I'll critique my own side of the industry, the academic side. We don't publish what doesn't work.
Yeah.
And that's a disservice to everyone.
100%.
Maybe we need to deal with that. So major pitfalls to avoid, that's the other side of the coin of what do you advise?
I mean, the one that kind of jumps to my mind is don't think that you know. And so coming in humble, coming in with a learning mentality, then that doesn't mean not articulating what you're good at or what you think your value is, but really coming together in the spirit of building something different. Unless you're, the king of value-based care and call me, I don't know who you are. I'd love to know who you are, but I do think that approach to we can do this, but there are parts of the equation that I can't do and that my partner needs to do. And if they can't do, then we really need to have a conversation. To me is just so critical. And then again, I don't think this is debated, but really we're trying to deliver care to patients, and don't lose sight of that. So those would be kind of the two things on both sides. Payer and provider coming to the table to try and make this change, I would highlight and reinforce.
Thank you. Melinda Durr, partner at EY-Parthenon. We sincerely appreciate all your contributions today.
Oh, thank you so much.
Look forward to talking again soon.
Me as well.